Hi, this is Modern Dental Assisting, Chapter 52, Removable Prosthodontics, Part 2. This chapter, or this part of the chapter we're going over is about the complete denture. So it's also known as a full denture or a plate, they used to call it. This is going to be for patients that are totally edentulous. And what edentulous means is without teeth. This is for when the remaining teeth cannot be supported with a partial. And when that happens, the rest of the teeth have to be extracted. The patient becomes edentulous. And another reason for this is if the patient refuses alternative treatment recommendations. So there could have been other things that could be done, but the patient decides they don't want to go through with other treatment options. So then they have their teeth extracted and they have the denture placed. There are contraindications to a full denture. And the first contraindication is if there's an acceptable alternative available. So a full denture can be difficult for a patient to wear. And if the patient is physical or has mental illness that affects the patient's ability to cooperate during the fabrication of the denture, or if and it makes them hard for them to accept to wear the denture, then we wouldn't do the full denture. So if a patient's hypersensitive to the denture materials, of course, we wouldn't make a denture for them. Or if they're not interested in replacing the missing teeth. Some people, that is not important to them to have those missing teeth replaced, or it's not in their budget. So you can't force something on a patient that they don't want or that they cannot afford. So you have to be sensitive to patient situations. Just because it's what is in their best interest for them for their dental health may not always be what's in their best interest for them financially, and we can't make them feel bad for something they cannot afford. When we go on to the components of a full denture, the first thing is the base, and that's designed to fit over the residual alveolar ridge and the surrounding gingival area. So the base is the biggest part of the denture, and it's typically made from acrylic, and that's to provide additional strength. However, it may be reinforced with metal mesh that's embedded into the acrylic. The flange is the part of the base that extends over the attached mucosa from the cervical margin of the teeth to the border of the denture. The flange of the mandibular denture base extends over the residual ridge and attached mucosa down to the oblique ridge and the mylohyoid ridge, and over the genial tubercles and the retromolar pads. The flange of the maxillary denture base extends beyond the residual ridge and over the attached mucosa to the tuberosities and the junction of the hard and soft palates. So retention of the maxillary denture depends on the suction seal known as the post dam. So we have to have that suction on the maxillary to make it stay up because of gravity. So that post dam is what makes that stay up on the maxillary denture. It covers the entire hard palate, and the seal is formed at the junction of the tissues of the posterior border of the denture. The post dam extends across the entire posterior portion of the denture from one buccal space across the back of the palate behind the maxillary tuberosity, which the tuberosity is the rounded area of the outer surface of the maxillary bones. And then, so it extends from the back of the palate behind the maxillary tuberosity to the opposite buccal space. The retention for the mandibular denture depends on the support of the remaining alveolar ridge on the suction achieved between the prosthesis and the tissues covering the ridge. So how much bone is left on the bottom and the tissues covering that bone. So achieving good retention of a mandibular denture can be difficult. And a mandibular denture lacks the broad suction area found in the maxillary denture, and the consistent suction action of the tongue can dislodge that denture. For those reasons, retained teeth or implants are desirable to help hold the appliance in place. Artificial teeth are fabricated from acrylic or porcelain, like I said yesterday. So the base with having the acrylic teeth, they're nice because you don't have that clacking sound and you don't get the breaks in them as easy, but they do wear down easier. So there are pros and cons to each type of teeth that you can have set into the denture. When we look at home care instructions for a full denture, we want to make sure that we have the patients thoroughly rinse the oral tissues at least once daily. That is very important to keep the tissues healthy and the blood flowing freely. All surfaces of the denture should be thoroughly cleaned with the use of a denture brush and a mild abrasive. So they should not be using a toothpaste, because toothpaste is too abrasive for the denture. Not bleach either. Bleach, of course, is very abrasive, and we're not going to want to put that on the denture. So when the dentures are not in the mouth, they should be stored in a moist, airtight container to prevent them from drying and warping. So there are denture containers that they should, denture baths they're called, that they should be put in, and they should put a little bit of water in them to keep them from drying out and cracking. They shouldn't be wearing the dentures at night. At night, they should be letting the mouth and the tissues breathe and let the air flow freely in the mouth and get some of that blood flowing, let the tissue get some airflow in there. So it's very important that the oral tissues are rinsed and that the denture is taken out at night and that it is stored in the denture bath or in water so that it doesn't dry out. In the first month, these are things to expect. On the first day, the patient's going to be adjusting to their dentures and their journey is just beginning. So with that, they have a lot of adjustments to expect. On days 2 to 14, their mouth is still adjusting to their dentures. They're still learning to talk and eat all over again, even through days 15 to 19. On day 30, they've made it through 1 month of their dentures. So their mouth is learning new ways to use their muscles to hold the dentures in place. They're learning how to speak. Their sounds are going to sound different. The different like S's and F's and things like that are going to sound different at first. They may sound like they have a lisp. So that will go away with time as they learn how to speak with these appliances in place. Eating will be different. So all of these things are going to be new to them, and they need to understand that it will come to them in time. They need to know that there is a period of adaptation with these dentures. There is something called an immediate denture. An immediate denture is placed immediately after the extraction of a patient's remaining anterior teeth, and it serves as a compress and bandage to protect the surgical site. So when you have traditional dentures placed, there is a long period between the extractions and the time the denture is placed for healing and bone regeneration. There is not that with immediate dentures. They're placed immediately after the extractions, the same day as the extractions, because they are used, like I said, as the compress and bandage at the surgical site. So, when the immediate dentures are placed, they are put in and they are not taken out for up to 48 hours. If they are taken out, then the swelling starts and the patient is not able to get that denture back in. With the construction of an immediate denture, it's completed with the anterior teeth in. So while the patient still has their anterior or front teeth in place, we take an impression and send it off to the lab and have the immediate denture fabricated. then it's sterilized and ready for placement at the time of the surgery. So when they make a surgical template, which is a clear plastic impression of the anterior area, and the surgeon uses it as a guide in properly contouring the remaining alveolar ridge. Then when the resulting alveolar ridge is satisfactory and the tissues are sutured into place after they remove the teeth, then they go ahead and immediately put that denture in. So they do the extractions like an alveoplasty, suture this tissue in place, and put the immediate denture in. 6 months after placement, an immediate denture will need to be replaced. That is the downside of that. So you have teeth immediately, and you don't have to go without teeth for 6 months, but then it has to be replaced because of the shrinkage after surgery and the bone loss. The next thing we're going to talk about is overdentures. A full denture that is supported by the bony ridge and oral mucosa plus 2 or more remaining natural teeth or implants. So this is when you still have 2 or more teeth in place or 2 or more implants in place, and the denture snaps onto those abutments. So they're either natural abutments or implant abutments, and the denture snaps onto those and to hold it in place so it doesn't rock around and it's not sloppy. And it's usually a mandibular denture that is an overdenture. So you have to prepare the teeth or the implants and place the denture. So what I mean by preparing the teeth is the teeth have to be so that they're not excessively bulky when the denture is snapped over them. So you remove much of the bulk of the teeth so that they're more like pegs that the denture snaps onto. So alternative techniques in the fabrication of dentures there are CAD/CAM machines that are for denture fabrications that you can do at the first appointment and initial impressions, and then at the second appointment, the remaining impressions, the color selection, scanning, minor modifications, and then you can deliver the dentures at the third appointment. Or with implant supported dentures, permanent placement may be called snap-in or snap-on dentures. So those are like the overdentures that instead of being called snap-on or overdentures, they're called snap-in or snap-on dentures. Now, when a denture is made and initially put in, there will be some bone loss or shrinkage afterwards. Relining is placing a new layer of denture resin over the tissue surface. So it's just the tissue surface of the prosthetic. So that's when there is bone loss or shrinkage of the bone, you reline the denture instead of remaking the denture so that it kind of fills it back in so the denture fits properly again. Rebasing the denture replaces the entire denture base material on the existing prosthesis without changing the occlusal relationship of the teeth. So you're putting a new base on the denture. You're not changing the teeth, but you're changing just the base part where like the acrylic shows for the tissue. That process includes tissue conditioning, new impressions, and a delivery to the patient. And that would be if you had a loose or ill-fitting denture, loss in vertical dimension, like lots of bone loss, inflammatory hyperplasia, or traumatic ulcers following lengthy, uncomfortable wear. So like if they were wearing it for a very long time and it was very uncomfortable, we may have to rebase it to make it fit better. So in relining, the prosthetic is resurfaced. In rebasing, the denture base is actually replaced. Sometimes a denture may need to be repaired, and a patient may call the office upset because their denture or partial is fractured or has a missing or loose tooth. Those problems are common And they can be caused by changes in the oral tissues, placing additional pressure on a certain area of the prosthetic, or just by careless handling. Maybe they dropped their denture or partial. That could cause it to crack or cause a tooth to fall out of it. Simple repairs can be done in the office laboratory, but if it's a more complicated repair, it will be sent out to an off-site laboratory to be repaired. So dentures can break in multiple ways, but depending on the type of break or the type of repair is going to depend on if your doctor is going to repair it in the office laboratory or have it sent out. So that will depend on how long the patient's going to be without their appliance. So you're going to have to know that whether they're going to be coming back that same day to have it given back to them, if they're going to stay there while it's repaired in an hour, or if they're going to come back the next day to get it pick it up, because it's going to go out to the lab today and come back tomorrow. So you're going to need to know these things when your patient comes in before they leave, so that you can schedule them. And then with denture duplication, because dentures can break and they require time for relining, you should always recommend that your patient have a duplicate denture. Patients find that having a duplicate is an excellent investment because they won't be without their denture if their original is damaged. A spare denture should be stored in a moist, airtight container. Now, it is very expensive to have a duplicate made, so they don't just usually opt to have one made right off the bat. But if, like, they have their immediate denture and then they have one replaced in 6 months, you would keep that immediate denture for the spare. Or when they have their original denture made, when they have their next one made, they keep that original denture as a spare. If they can afford it, they go ahead and they have one made as a spare. But dentures are expensive, and we don't expect patients just to have one made as a spare, but we do recommend it if they can have one. So there are some appointment scheduling, and I do want to go over that with you. So for the appointment sequencing for a full denture, the first appointment is the records appointment. In that appointment, you would do an updated health and dental history, and you would do the preliminary impressions with an alginate impression of the edentulous arch, which differs from other alginate impressions in 2 ways. The height of the teeth is missing, and you have to have more extensive detail for the tissues because you don't have the teeth there. So an edentulous tray will be used to take this impression. An edentulous tray is not as deep, but if the tray requires modification to accommodate space and depth in the mucobuccal fold, rope wax will be added to the borders of the tray. Tray modification allows border molding, known as muscle trimming, to achieve closer adaptation to the edges of the impression to the tissues of the mucobuccal fold. So we just would push the tissue or the impression material closer to the tissue because we need to get a really good picture of what the tissue looks like, since we're not getting an impression of any of the teeth. In the second appointment is a final impression. Remember, only final impressions can only be taken by the doctor. So the dental laboratory technician requires a final impression to create the base of the denture. Before the impression is taken, a custom tray is fabricated. So we make a custom tray based off the preliminary impression that you took at the first appointment. So the custom tray only fits the patient's mouth that it is made for. So a custom tray is constructed from the diagnostic cast from the first appointment. And then after that, based on the accuracy, because accuracy is essential, an elastomeric impression material is selected for the final impression for creation of the base plates and the occlusal rims. At the third appointment, you try in the base plate and the occlusal rim, and then we look to see the vertical dimension, which is the space occupied by the height of the teeth in the normal occlusion. So we want to see how high the teeth are. We want to look at the occlusal relationship, the centric, protrusive, retrusive, and lateral excursions, how the teeth move in all the directions. The smile line representing the area of the teeth in the that's visible when the patient's smiling. And the canine eminence, which is the vertical line that indicates the locations of the canines. We want to look at all of that and make sure it's in the right spots. If not, we want to move it because these teeth are set in wax. It's easy to move so that the lab can change where those teeth are set and then send it back to us to try it again. And then at the fourth appointment is the try-in appointment. The wax setup consists of the base plate and the artificial teeth are set in wax again that resemble the gingival tissue and the shaping of the wax to simulate normal tissue, contours, grooves, and the eminences known as festooning. At the fifth appointment is the delivery. So at the fifth appointment, we have now approved everything and we have delivered the appliance to the patient. We want to make sure that the dentures are disinfected before they're placed in the patient's mouth. At the sixth appointment is the post-delivery appointment. It's scheduled 2 to 3 days after the delivery of the denture, and it's a 10 to 20-minute appointment is usually adequate for that visit. The dentist checks the denture and checks the mucosa for the pressure spots and sore areas. If necessary, they make any minor adjustments to the denture, and if the patient needs more than one adjustment, or the patient may need more than one adjustment appointment after the delivery for the complete denture, just to make sure that all of the sore spots are taken care of. Thank you.